So firstly, I'd like to acknowledge the traditional custodians of the land on which we're meeting this evening, the Ngunnawal people, and I wish to acknowledge and respect the continuing culture of the continuing contribution they make to the life of this city and our region. And I'd like to welcome any Aboriginal and Torres Strait Islander people who are joining us for this evening's event. So my name's Anne-Marie Swoboda, I'm a GP and I'm the Medical Director of the GP Liaison Unit at Canberra Health Services. And I wanted to thank our sponsors this evening, Capital Health Network, who are assisting us with tonight's education event. Just want to remind everybody to please remain on mute this evening and to turn your videos off. That will help to keep the stability of our platform as we run the program this evening. There will be plenty of opportunity for questions with the panels, and we'd like you to put your questions in the QA box addressed to everybody so that we can see them as we go along, and I'll field them and ask them as we go. So I want to firstly introduce our presenters this evening. So we have with us Associate Professor Boon Lim. Boon is the Clinical Director of Division of Women, Youth and Children, and he's a Senior Staff Specialist at Canberra Health Services. We also have with us Professor David Elwood. David is an obstetrician gynecologist and he's the Director of the Fetal Medicine Unit at Gold Coast Health, and he's the Co-Director of the Stillbirth CRE.
Good evening, everybody.
We also have Christine Andrews with us. Christine is the National Coordinator of the Safer Baby Bundle, and she's a postdoctorate researcher who specialises in perinatal implementation research. We also have Julianne Nissen with us. Julianne's a midwife. She's the Clinical Midwifery Manager of Maternity and Gynaecology at Canberra Health Services. And we have Dr. Jess Nathan, who is a GP in private practice with experience in antenatal care, and she has a special interest in women's and children's health. So I'm going to hand over to Boon now, who's going to do a presentation for us on the Safer Baby Bundle.
Thank you. Thanks, Anne-Marie. Thanks for the introduction. So hello, everyone. As Anne-Marie said, I'm the Clinical Director, Division of Women's, Youth and Children. I'm an obstetrician. So it's really great that Capital Health Network is sponsoring this webinar tonight for us to spread the education on the Safer Baby Bundle. Let's go on with the acknowledgement of country again to acknowledge the traditional custodians of the land we're meeting on, the Ngunnawal people. And also for those who are dialing in from outside, the custodians of the lands that you're meeting from as well, and acknowledge the elders past, present, and emerging, and welcome any other Aboriginal Torres Strait Islander members to this webinar. So I'm going to spend the next 20-25 minutes talking about the Safer Baby Bundle and then open up for panel discussion. As Anne-Marie has already introduced the panelists, and this is the list of panelists that will be meeting tonight. So what is the Safer Baby Bundle? Some of you will already be familiar with it. It is a national initiative with 5 evidence-based elements to address key areas where improved practice can reduce the number of stillborn babies. This is based on the best available evidence and is led by the Stillbirth Center for Research Excellence, and the directors you've already noted is Professor David Elwood and Professor Vicky Flanady, who may or may not join us tonight. The goal of the Safer Baby Bundle is to reduce stillbirth from 28 weeks gestation by at least 20% by 2025. When it was initially launched, the aim was to reduce it by 23, but clearly COVID caused a significant delay to the program, and hence the revised date has been set as 25. The bundle consists of 5 elements: that's smoking cessation, fetal growth restriction, decreased fetal movements, side sleeping, and timing of birth. And I'll expand a bit on those with a focus on a little bit of practical approach as well. And then we can take questions at the end. So the aim of this evening is to help identify strategies to support women to stop smoking in pregnancy, improve the detection and management of fetal growth restriction, raise awareness for women, for fetal movements, improve awareness of side sleeping in late pregnancy, and also the improved decision-making around timing of birth for women with risk factors for stillbirth at or near term. What is important is that there's lots of resources available, and I would encourage people to access the resources, and there's an e-learning package which is very easy to go through, and that will help you to understand the bundles, the program even much better. And there's plenty of resources available that you can actually download for your practice as well. So that's the link, and when we send out the slides, it should be available for you to click on into. So just a little bit of background, what's been happening in the ACT. We launched the Safer Baby Bundle in the ACT in December 2020. There's been a lot of promotion in the participation in the e-learning module. There's been a very good take-up, principally by midwives and obstetricians, and we're trying to encourage GPs to access it as well, and you'll get CPD points for doing it as well. There's been implementation workshops that was held initially in 2021, and we just held our second workshop on the 19th of May 22 with implementation plans drawn up. Champions have been identified for each of the elements of the bundle, and champions across both sites, Calvary Public Hospital and Canberra Health Services, have been identified, and they will help to lead the implementation of the packages. But you as GPs, it will also be helpful if you can help to reinforce the aspects of the bundle, the elements as well. And there are some of us have participated in the national workshops as well. So what is the impact of stillbirth? Clearly, I'm sure all of you will know it has significant psychological, emotional, and social impact, causing distress, increased healthcare costs, and negative effect on people who look after women and family bereaved who've been affected by the stillbirth. And we know that the stillbirth can lead to guilt, family breakdown, stigma, abandon, and abuse. And then clearly there are ongoing long-term effects in terms of employment, maternity, paternity leave, and healthcare expenses as well. So although the numbers tend to be small, and particularly in a small jurisdiction like us, but the impact, the effect on those who are affected will be significant. The stillbirth rates in Australia, in terms of the overall stillbirth rates, have been running relatively steady, and that's the aim of trying to reduce the number of stillbirths. So in 2018, the stillbirth rate in Australia was 6.7 per 1,000 births, and that equals to almost 2,200 babies in Australia being stillborn. There have been some decline in stillbirth rates after 28 weeks, but there's still room for improvement. And the early stillbirth, the very early stillbirth, and that's this white line, still shows a rising trend. And stillbirth rates, like most of the other health indicators, affect the Aboriginal and Torres Strait Islander women disproportionately. In 2016, the stillbirth rate for Aboriginal Torres Strait Islander women were 10.6 per 1,000 births, compared to non-Indigenous women of 6.7 per 1,000 births. and the more remote the women are, the rates are higher, and high smoking rates contribute to further increase. And also perinatal death was twice as common in indigenous women with pre-existing diabetes. And it also affects migrant and rural refugee populations as well as those with significant socio-economic circumstances. The causes of stillbirth, it is important to note that you can actually classify them into those before and after 28 weeks. There's a high percentage of unexplained antepartum deaths after 28 weeks. So there's a lot of work that needs to be done in this space. And improving the audit of perinatal mortality will help to identify the causes. In the early stillbirth group, congenital abnormalities form the significant proportion of them, but in the later stillbirth group, as I said earlier on, unexplained antepartum deaths contribute the biggest group, followed by growth restriction and hypertension. So whilst these may be modifiable causes, unexplained stillbirth still needs a lot of understanding. The maternal factors that affect stillbirth shows that the adjusted odds ratio, which shows increased risk factor in women compared to those who don't have risk factors, again show that women who smoke are at 1.4 times more likely to experience stillbirth. So if all women stop smoking, between 4 and 7% of stillbirths could be prevented. A lot of these factors are modifiable, and they are focused in the Safer Baby Bundle. For example, still smoking, position for sleeping, and also the lower economic circumstances as well. So the risk factors in stillbirth, the pregnancy and medical risk factors include small for gestational age, previous stillbirth, pre-existing diabetes, hypertension, Rhesus disease, preeclampsia, and postpartum. So it's important to identify, especially small for gestational age babies, to reduce the risk. So as I said earlier on, the goal is to reduce the stillbirth rate by 20% by 2025, and that consists of the bundle. So, and that's why there would be the Australian Safer Baby Bundle. So why do we use bundles? We know that bundles of care can save lives, and that's been demonstrated in the UK, where the Saving Babies Lives care bundle, which are slightly different to the Australian ones, have already shown a 20% reduction in stillbirths. In Scotland, there's been evidence of 22.5% reduction in stillbirth. The focus in Scotland has been mainly on smoking cessation, and that's been shown to be successful following the program launch in 2013. So I'll just talk now, spend some time on the individual elements. Smoking cessation. I'm sure all of you in your practice will come across women who smoke, and currently 1 in 10 pregnant women smoke, and disadvantaged women are at rates 3 times compared to those who in the less disadvantaged group. So women who smoke are 1.4 times more at risk of stillbirth. And as you know, smoking during pregnancy is associated with low birth weight and gestational age. So the recommendations is to follow an ask, advise, help model of care, and that you ask at your first antenatal visit and document the tobacco use, and where available, record the exhaled breath carbon monoxide. Now, this is something that's being implemented in both the hospitals. The smokerizers have been purchased in both hospitals, and there'll be education that will be rolled out to for midwives to use that as a monitoring tool to assess the level of carbon monoxide and to help incentivize smoking cessation in the women that they see. Clearly, we're not asking GPs to do that, but I think it's important that at least the questions are asked about smoking cessation and identifying where to refer women who should be advised to quit smoking. So these are the questions you can ask about smoking status. I smoke more since pregnancy. I smoke less since pregnancy. I'm smoking the same. I used to smoke but quit. I've never smoked. One of the common things I find in my clinic when I ask women about smoking, the first answer I get is, "Oh, I've cut down," without telling you how many they smoke. So we need to spend a bit more time to identify that. It's also important to stress, the effects of smoking on pregnancy, and hence explain the importance of smoking cessation. So the effects would include placental abruption, congenital abnormalities, sudden infant death after birth, obviously, miscarriage, preterm birth, and also the baby's development. So it's important to reinforce the benefits of quitting at any stage in pregnancy. You can offer a referral to Quitline and consider offering nicotine replacement therapy. We do in our antenatal clinics, we will be able to access nicotine replacement therapy for the women should they wish to have, or we can refer them to Quitline. And at Canberra Health Services, we've been working with the smoking cessation service as well to refer them to women, to refer the women should they wish more advice and help. So these are the resources that are available online, and you can print them. You can actually print them, or you can provide these links to the women that you see in your clinics as well. Fetal growth restriction is an important cause of stillbirth. It's strongly associated with stillbirth and increased risk of neonatal mortality and morbidity. It's also linked with long-term adverse outcomes and impaired neurological and cognitive development, and ongoing chronic disease as well. So what we know is that improving detection and management of fetal growth restriction or small for gestational age are important strategies to reduce stillbirth. So if FGR is not detected, the fetus is 8 times more likely to be stillborn, and less than 1/3 of growth restricted small for gestational age babies are detected antenatally. So it is important for all caregivers, all clinicians to understand and screen for fetal growth restriction. So these are the recommendations: identifying women at risk factors, standardizing the symphysial fundal height measurement, consider commencing women at with low dose aspirin, can be 100 to 150 milligrams at risk of preterm preeclampsia, and discuss a plan for monitoring fetal growth based on risk factors. And if there are significant risk factors, then you come up with a plan of ultrasound surveillance as well. But there are modifiable risks that can be addressed, things like smoking and substance abuse cessation as well. Other risk factors include the older mother of age of over 35, in vitro fertilization, nulliparity, high BMI, low PEPE, and previous growth restriction as well. So this is the fetal growth restriction care pathway. Again, this is a very busy slide, but as far as GPs and primary care givers are concerned, it's important to screen women, identify if they've got no risk factors, and they go on the standard care pathway. And if they've got risk factors that include what's listed here, then you discuss growth surveillance. And clearly, if there are significant high risk factors, they would be referred to FMU. So a GP conducting shared care can be involved in this level 2 screening and a care pathway. So it's helpful to understand the care pathway, which again is in the resources that I've spoken about. So what can the GP do? You follow the pathways based on the risks, ensure that there's consistent symphysial fundal height measurement at each antenatal visit after 24 weeks, arrange for ultrasound scan for fetal growth as clinically appropriate, and refer to the antenatal clinic or FMU as per agreed pathway. Clearly, if you're concerned, give us a ring or refer to the maternity assessment unit. Again, resources are available and posters can be printed. And we do have posters available that can be put up on the walls. Just coming on to decreased fetal movements, I think the key message here is that this should be, women should be made aware of what to expect in terms of fetal movements, because there are concerns about reduction in strength and frequency can be associated with up to a 4-fold increase in stillbirth. What is important is that all pregnant women should be given information about what to expect with regards to fetal movements, including the strength, frequency, which normally stay the same or increase as pregnancy advances, and healthy fetuses are most active in the evening. What is a myth is that cold drinks and food will help to improve, will stimulate fetal movement, and that is not supported by evidence. And also kick charts are no longer useful in terms of providing good evidence for fetal movements. So it's about women perceiving their movements and reporting a reduction in movements to you that need to be listened to and taken account of. So the path to follow would be the initial response. Don't delay seeking help. So if a woman comes to you, after 28 weeks and tells you that they've got reduction in fetal movements, it's important to assess her, and if necessary, and if there is, she reports a reduction in fetal movement, send her up to maternity assessment unit for assessment for a CTG, and then we'll, depending on the circumstances, we'll provide further investigation and birth planning. But it's important to counsel women well before 28 weeks so that they understand what to report and how to report their fetal movements. So these are the resources available, and these are again a very detailed resource about the actual management pathway, and more posters that can be available and be put up on your surgery walls. Side sleeping, again, we know that the gravid uterus can compress on the inferior vena cava, impeding return of blood flow to the heart. And it's been shown that maternal supine, going to sleep position, is a risk factor for stillbirth after 28 weeks. And in the meta-analysis, it attributes 5.8% of stillbirths. So this indicates 1 in 17 stillbirths can be avoided if the women sleep on their side from 28 weeks. What is important is women sometimes do panic when they say, "Oh, I wake up and I sleep on my back," but it's highly unlikely that she'll sleep on her back for the whole duration of her sleep, and you can reassure that it's normal to change position, but as general advice to encourage them to sleep on their side, and they can sleep on any side, left or right as well. Again, these are more posters that can be made available. And timing of birth. There's a lot of work that's being carried out currently between the Stillbirth CRE and the Australian Preterm Birth Prevention Alliance to work out the optimal recommendation for timing of birth. So there's still a lot of work that's still being done, and there will be more information that will be made available. But it's important to identify risk factors and to give advice on the best planned time for birth. So I wouldn't spend too much time on this area because there's still a lot of evidence that needs to be looked at and advice being given. So it's important to identify risk factors early, appropriate tests, reassess again at 34 to 36 weeks, 36 plus 6, and plan for increased surveillance where indicated, and to have a shared decision making on the timing of birth. So the Safer Baby Bundle is about communication. I think it's important to stress the communication between the clinicians and the consumer, the women. It's important to have a discussion about risk factors and provide information in a clear and easy to understand way between health professionals and their consumers. Because very often the messages, the feedback that we get is that clinicians, there seems to be reluctance in discussing stillbirth or stillbirth prevention, and also reluctance in providing adequate information about stillbirth prevention as well. So communication is important between clinicians and also between the clinician and the consumers. So continuity of care has been shown to be important. It's key to improving outcomes. Continuity of care doesn't mean just purely obstetric care or midwifery care, but also it can be shared care as well. So as long as women are familiar with their caregivers and there's good exchange of information, they do lead to improved outcomes as well. So as I said earlier on, the e-learning module is available, and that's the link that's available. Provides free education training, gives you CPD points for doing it. There are short chapters accessible on all devices. It's interactive, and you've got resources that can be downloaded. So I would encourage you to register and participate in the e-learning modules. So that is the end of my talk. These are, again, the resources available. This Safer Baby Bundle it has received federal recognition and also endorsement by several organizations and colleges as well. It's a very important piece of work, and you know, it's the aim of which is to reduce stillbirth, which is a significant health risk. So I will now hand you back to Anne-Marie to start the panel discussion. Thank you.
Thank you so much, Boone. That was really useful overview of the Safer Baby Bundle learning. I have to say, I did all the modules and finished it last night, and it was a really good program to do. And it was actually something I hadn't thought about very much from a general practice perspective, talking to women about stillbirth. So it was a real eye-opener for me, and I found it quite helpful. It was very user-friendly. It was very easy to do and useful. So thank you to our panel members. We've got a couple of people on the panel. Jess, I can see you've got your video on, so I'm going to come to you first to just ask you from a GP perspective about how you approach that discussion with women, and have you been having discussions with women about their risks for stillbirth?
There's so much to cover in antenatal care, particularly in those first few visits. I don't think it was a specific discussion that I was having, but rather, you know, in the history taking, you would ask about smoking, and as the pregnancy continued, you would at each visit talk about fetal movements and measuring the height. And I think also probably relying a lot on the midwives who they're seeing at the antenatal clinic to be educating patients on that, and then we would be more reinforcing that information. But I definitely found like doing the Safer Baby Bundle was so helpful, because I think it is all things that we are already talking about, but it gives you the why, and it gives you the why in a really easy way to understand and to explain, with a lot of really good resources. So it was very, very valuable. Highly recommend.
I agree, it was very good. So perhaps some of the other panel members, so maybe David, going over to you. So how do you think that we should start the conversations with our patients about stillbirth and their risks?
Thanks, Anne-Marie. And look, before I answer that, I just wanted to acknowledge the fact that the response that we've had from the ACT to implementing the bundle has been just absolutely fantastic. Boone's been a great champion. We've also been really fortunate that Anthony Domkin, your Chief Nurse and Midwifery Officer, has been incredibly supportive and has put resources into the rollout of the bundle. He himself is a bereaved parent who freely sort of talks about the loss of his stillborn baby many years ago, and it's been just amazing trying to work with all of the different jurisdictions, particularly through COVID. It's been incredibly challenging, but this truly has become a national stillbirth prevention program that the ACT really has gone the extra mile, I think, which is fantastic. Just to respond to the question, I think we're guilty of talking in euphemisms, of saying, you know, perhaps it would be good to get this baby out before we run into trouble. Perhaps we should, you know, that it's time for this baby to be born. It's been sort of cooked for long enough. I mean, there's all sorts of ways that we talk about the end of pregnancy as being a time of risk for the unborn baby. And there's no doubt the longer you remain pregnant, the higher the risk statistically. But women want us to talk about stillbirth. They want us to use the word, and I think it needs to be discussed in a very gentle way in pregnancy, but particularly for those who do have risk factors. I mean, women who smoke, women who do have fetal growth restriction, women who you are concerned about for other reasons, accumulation of risk factors for stillbirth, maternal age, maternal BMI are two of the most prevalent problems that we have now in pregnancy. Although the overall risk one is not that great, by the time you start to add them all together. And of course, one of the things to recognise, and this is true for virtually every adverse outcome of pregnancy, is that being in your first pregnancy is a major risk factor. being in your first pregnancy, if you look at the adjusted odds ratio on the slide that Boone showed, gives you the same kind of risk as for many other of the demographic risk factors, such as maternal age and maternal BMI, and that's not very well recognised. So I think the message is to use the word stillbirth, to talk about it freely as one of the things that can occur. You know, it is fortunately very rare. I mean, for most women, we're talking about risks that are measured not even in 1 per 1,000, but sort of 1 or 2 per 10,000 if you have a normal pregnancy. But it is the most tragic outcome of pregnancy, and you know, we really do need to talk about it very openly. Thanks,
David. Julianne, from a midwife perspective, how would you start that conversation, and when is the best time from your perspective?
I think the best time is actually every single pregnancy visit, antenatal visit. I know it's commonly asked in the first visit, and it's just a standard question, but it's not commonly asked repeatedly, if that makes sense. So that's we're putting looking at options for the midwives for motivational interviewing, so that they on how to ask the questions and centre around that smoking cessation. But we found the best results is if we've identified that the woman is smoking, got a plan in place, you've done the referrals, and then again they've followed up every single visit on how they're going.
Thanks, Julianne. And yeah, I hadn't made the connection. Sorry, Julianne, I'm just going to mute you. I hadn't quite made the connection. I understood that smoking caused fetal growth restriction, but hadn't quite made that connection in my mind about then that next risk with stillbirth. So actually that was a really important thing for me as a learning. We've had a couple of questions about smoking cessation come through in the questions. Somebody has asked, is cutting down smoking to 5 cigarettes a day sufficient? Boone, do you want to have a go at answering that one?
Yes, I think that's an interesting question, because I think whatever it is, we must try to encourage women to stop smoking. But I think for some it is a challenge to stop smoking completely, and that's when we should try to offer alternatives like nicotine replacement therapy. You know, it's more freely available now, and therefore I think that would be the strategy that we should try. Yeah, like I said, you know, the most common answer I always get is I've cut down, rather than say I've reduced or I'm going to stop. And there, I think it's trying to get them motivated to stop, and I think that's been found in the studies from Scotland, particularly when they use the smokalizer to help women, to incentivize them, you know, to help them to measure the carbon monoxide level and incentivize them to, you know, continue reducing smoking to the point where they would stop smoking. And the evidence, and showing them the evidence in terms of correlation between smoking and stillbirth rates as well. I think that would be the important strategy to adopt.
Yeah, and we'll have some of those smokalizers available, will we, in Canberra?
We actually do have them already. We bought them before COVID, but obviously we didn't actually launch them because of COVID, because of the you know, the aerosol risk. I believe Calvary has also purchased a number of smokalizers as well. Okay. So we're going to educate the midwives on how to use it, and to learning from elsewhere as well how to use it and what's the best approach. We don't want to use that as you know, a tool to stigmatize women, but you know, it's more an education and incentivizing tool.
Yeah, I think those things can be very powerful to motivate people to change when you actually see, you know, some numbers in front of you, and then can relate it to the impact on growth and the fetus. That's a very powerful tool to use. We've got a question from one of the GPs about nicotine replacement products. She wants to know, what nicotine replacement products do you use in pregnant women?
Perhaps Julian Julian and I worked on the initial rollout of our nicotine replacement therapy. It must be about 3 or 4 years ago now, when we got some funding from the public health department. I'll hand over to Julian to see to speak to that.
So they advised the gum at first to use. The thing with the gum is you just have to keep, once you've chewed it, keep it in your mouth at the side. And we found that, not that we've used it a lot, but that women found that difficult. There is this spray, there are the patches, but the gum is what was recommended initially that we were using. I think though we have, is that correct, Boone? We've got the patches now.
Yes, we have. And Dr. Rodrigo from the smoking cessation, he's a respiratory physician who runs the smoking cessation service in the hospital. We've been working with him, try to develop the pathway for smoking cessation for our pregnant women as well. Although his clinic's extremely busy and it's very difficult to get people to go into his clinic, but he's very helpful.
Yeah. So we did have a comment from one of the GPs online also about, why to refer to TCH smoking cessation clinic rather than back to the GP, who actually does have, the skills and the capacity to be able to talk to women about smoking cessation. Can we offer through the hospital clinic free nicotine patches? Is that what you were saying? There's access to reduced rate or free patches through the clinic?
Yes, there is. That's free nicotine replacement therapy through the Canberra Hospital or through the antenatal clinic. And it's there for the midwives and the doctors to use, to offer it to the women. And then with the partners can get it through this Canberra Hospital smoking cessation clinic.
Thanks, Julianne.
I believe in Calgary, the pharmacy will be providing that as well. I think they've got a pharmacist who's joined their smoking cessation sort of group, and they'll be providing that there as well.
Thanks, Boone. So we have a question from Lynn, who's asking what might be the comfort or discomfort of clinicians, in particular midwives, in using the word stillbirth in antenatal care, bearing in mind that there is a general discomfort in talking about death. It's a tricky one.
It is always a tricky one. We're trying to get them to be part of the antenatal appointments and to gently use that word. We want to, we've got the Safer Baby Bundle, we've got all the posters in the clinics and in the rooms. We've purchased a lot of we've got quite a few of the small handouts now, and it's just a discussion on how it can reduce the stillbirth rates. And we let them know that our midwives, we're trying to educate them that 1/3 of all stillbirths can be preventable. So it's just trying to get those midwives to step outside of the comfort zone. The more they do it, the easier it is. Women want to know this information.
Yeah. Steve, did you have a...
Can I just jump in, Anne-Marie?
Yeah. I was going to ask Christine, but that's okay, you go.
So one of the things I was going to say is that even though stillbirth is relatively rare in pregnancy, it's not so uncommon that most women will know somebody or know somebody who knows somebody who's experienced stillbirth, or it's there's a family member who's experienced stillbirth. It is still common enough that people are aware of it. Yet we don't talk about it. And I think women really do want us to talk about it. The point I'm comfortable about talking about death. But I think that's perhaps one of the reasons why we do need to start talking about it early in pregnancy and just make it no longer a taboo subject that you can't talk about. Because really, a lot of the interventions that we use in pregnancy are around preventing adverse outcomes such as stillbirth. So I think we need to be honest about why we're doing various things.
Thanks, David. Christine, did you have something you wanted to say about
No, I guess it was along those lines. You know, we have done, when we were developing the resources, we did a lot of surveys and focus groups and interviews with women, and that was certainly something that came out very strongly. But I guess the other point from Julianne was, as we've been hearing back from midwives and clinicians that have been using the resources in some of the other jurisdictions, one of the things that they've said is just by virtue of actually having that resource or having that pamphlet that actually has the word stillbirth on it has allowed them to sort of introduce that topic and get more comfortable. And once they've started doing that, they've been able to sort of progress from there. So, you know, it's obviously difficult, but we are hearing some good feedback around that.
Thanks, Christine. So we've got a couple of questions coming in still on this smoking theme. Sorry, don't seem to be able to get off it, but a couple of questions about vaping, because this is a growing trend in our community, particularly our young women population. Can anybody on the panel comment about, you know, what information we should be giving to women about vaping during pregnancy? And, you know, are there risks associated with vaping? Do we know? Silence. Who can tell us? Jess, do you have some experience?
I can try and tag in with information I learnt from the Safer Baby Bundle, which basically said, you know, I sort of think of it in the same realm of alcohol in pregnancy and vaping in pregnancy, in that we always explain to women that we don't know what a safe amount is, so we recommend not doing it at all. And similarly with vaping, it is, we don't know, we don't have enough evidence, and so it's better to avoid it to keep you and your baby safe.
Thanks, Jess. Very sensible advice. I think that's really useful. Julianne, did you have anything else you know about vaping?
No, we would treat it the exact same way.
Yeah, okay.
Anne-Marie, I think I saw an article the other day that, you know, although vaping was meant to be nicotine free, but there are now products that contain very high levels of nicotine in them as well. So, you know, it is an unknown quantity. So I think it's best to avoid them. Yeah.
And coming back then, sorry, still on nicotine and nicotine replacement therapy, is it, are the risks with the fetal growth related to the act of smoking, or does nicotine replacement therapy also carry a risk because of the effects of nicotine on placenta?
Well, perhaps I can respond to that. I mean, the studies on nicotine replacement therapy in pregnancy are relatively reassuring in terms of the risks of fetal growth restriction. The reason why smoking causes fetal growth restriction, I mean, there are multiple different effects. It's not purely a nicotine effect. It's that there are lots of different toxins in cigarette smoke and a number of different mechanisms that have been identified. So we've got pretty clear evidence about the safety of nicotine replacement therapy in pregnancy.
Thanks, David. So finally, I get to move off the question of smoking. So Boone, perhaps to you, a question: is it essential to measure symphyseal fundal height when you already have the ultrasound report telling you about a baby's growth?
Thanks, Anne-Marie. Well, short answer is yes. I think it's it's more than likely that there may be more than one practitioner who will be looking after the woman in pregnancy, and it's important to be able to measure the fundal height to show the trend of growth, so that you know, one ultrasound scan at that one point in time may not necessarily give you information as ongoing trend. So there might be other things that might happen during the course of pregnancy after that scan that will cause slowing of fetal growth, and therefore it's still important to measure symphyseal fundal height. So it's as long as it's consistently done, it's reproducible, and it shows a trend, that's important.
Yeah, and I noticed that there were some video demonstrations in the Safer Baby Bundle package to remind people how what the best technique is. And I think, Christine, you may have actually put the link on as well in the chat box somewhere there.
Yeah, that video is available on the website. You don't have to necessarily go through the e-learning. You can grab that as a standalone.
Yeah, and I guess just from my point of view as well, is it important that it's the same person doing it, or does it matter that there'll be different people doing that measurement? You know, midwife one time, a GP another time, different midwives? How consistent does it have to be?
I think my response to that is that one of the important things about having a standard technique and actually charting your results so you can sort of plot them on a standard sort of chart does allow for that, you know, different people making measurements at different stages in pregnancy. But I think it's one of the aspects of the importance of continuity of care. I mean, I think the same person doing the same measurement sort of time after time after time is inevitably going to lead to more accurate results. It's one of the reasons why I think continuity of care is important.
Thanks, David. Where do we access those charts to record the fundal height? Because I've actually never seen those before. The first time I'd seen them was when I did the education program.
We've actually built the charts into at Canberra Health Services. We've built it into our BOSS program already. It's not built into the birth back program in Calvary because of the technical issues, but we're actually going to build that into the DHR, the digital health record, the EPIC digital health record that's rolling out in November this year. So we're trying to find a way that we can actually print it off for women to carry as well. That's still in discussion in the bill phase. So I'm not sure if any of the people involved in the technical aspect of building the EPIC program are here, but I think that is the plan. Michelle just said they're talking about putting it in the handheld record. So.
Okay, yeah, I think Boone, that's really important, because if we're having that, you know, shared responsibility, having access to that information that the midwife has already tracked and logged is so important. Otherwise, the GP can't really, you know, you're having it out of context if you just do a one-off measurement, aren't you?
Yes.
And just a note, there's a comment from Kirsty in the chat that she's come up twice now. Can a GP refer a pregnant patient into TCH pharmacy to access the free nicotine replacement?
Okay.
I don't know the answer to that, but perhaps somebody can answer that.
Who can answer that? Julia?
Oh, I just know if they're having their baby at the Canberra hospital, they can access it.
Yeah. So is it pharmacy or through?
Through the antenatal clinic, the midwives and the doctors, the obstetricians can give it. It's there, and it's through. I mean, it's even in the continuity program, it's upstairs in theirs. I think we've got it in the fetal medicine unit as well.
Okay, thank you.
Julianne, what about somebody very early in pregnancy? I mean, do they have to wait for their sort of booking in visit? I mean, I think sometimes the earlier you get to see somebody, the more effective the smoking cessation strategies are. Yeah,
I agree. We've got a bit of a process though. So at the very first visit, we talk to them about it and see if they can reduce it, and then at the next visit, if they are having problems with the reduction, then we can offer the nicotine. So I suppose the earlier you see the woman, the earlier then you would see them maybe then at 20 weeks, and you could have that question. But if you see them a bit later, then that kind of delays the whole process, because there's a bit of a pathway for the midwife to follow. I don't think we can do it straight up. Is that correct, Boone? We just can't offer it for the first visit.
Yeah, the aim is to get them to try to reduce it themselves, because we don't want to if they still continue to smoke a reasonable amount of cigarette, then, you know, giving them nicotine replacement therapy might give them more than is desired. So we're trying to get them to cut down in the first instance. We are actually Julia Smythe, who was the midwife, was supposed to come this evening, is finalizing the guidelines for pregnancy, nicotine replacement in pregnancy as well. So we should have one hopefully soon.
So Boone, we've still got a couple of minutes. So I was just going to ask about referral pathways. So if a GP is concerned, they're seeing one of their pregnant women and they're suspecting that there's reduced fetal movements or growth restriction, what's the best way for a referral pathway? What should we be doing?
If there's concern about fetal movement, then the best thing to do is to get them to go up to the maternity assessment unit, where they can be assessed appropriately and CTGs, etc. If say they're measuring, if you know, in the clinic, in your surgery, the woman's measuring small, you can should be able to hopefully access an ultrasound scan soon to assess fetal biometry, and if that confirms or highly suspicious of growth restriction, then by all means send them up to the antenatal clinic, or if it's significant reduction FGR, then FMU.
And do we need to ring anybody in advance to let them know? What's the best?
Oh, well, the best thing to do, I mean, obviously, if there is a significant concern, just ring the registrar on call.
Okay. Okay, it looks like I'm sort of coming towards the end of my questions. I did have another question about aspirin, Boone. So it was around risks of preeclampsia. Can you just very quickly in the last minute or two go back over what the risk factors were for preeclampsia and who exactly should be getting aspirin?
Well, the being nulliparous is well, first baby is already a risk factor, but some places are doing the screening during the first trimester scan to work out the risks of preeclampsia as well. But you know, in terms of clinical assessment, previous growth restriction, hypertension and pre-existing hypertension, you know, previous say diabetic women as well, and if it may not necessarily be is someone who's had preeclampsia, but in the past as well would be at risk as well. So those are the I'm sure there's a more exhaustive list, but that will be the ones that come to mind.
Thanks, Boone. David, did you have something else you wanted to add to that?
Just to say, I think the gold standard these days is first trimester preeclampsia screening at the 12-week scan, and you know, I think that's gradually going to be introduced across the country. We've just introduced it at the Gold Coast, and there's Safer Care Victoria are going to introduce it across Victoria as well. So I think that is the gold standard. I mean, there's quite a wide range of risk factors for people on for preeclampsia, but I think there's certainly arguments against giving aspirin to everybody. I think we need to be a bit more targeted than that.
And David, will it become standardised on the reporting?
Well, if preeclampsia screening is being offered by ultrasound practices, then it is a standardised reporting system. There's a standard sort of software package that you need to use before you can calculate the risks.
Yeah. Okay. Thank you. Well, I think that's bringing us to the end of our questions. I'm just going to quickly scan. I think we have covered all of the questions that we have in the chat box. So thank you, everybody, for joining us this evening. I want to particularly thank our panellists this evening, to Boone, to David, to Jess, to Christine and Julianne for giving up their time to speak with us. Thank you to all the GPs and midwives who have joined us this evening. Just a reminder that there'll be an evaluation sent to you, and that if you aren't an RACGP member, you'll still be able to claim points with your relevant college. And thank you again to CHN, our partners, in organising this tonight. Without their help, we wouldn't be able to put this together. So have a good evening, everybody, and we'll see you next time. Bye.
Thank you.
Bye, everybody.
Bye.
Good night. Thank you.